You know, when you picture a massive breakthrough in cancer treatment, your mind probably goes straight to the weapon itself. Like, you imagine some new, highly advanced chemical compound or a targeted laser or, I don't know, a genetically engineered cell that just hunts down the disease. You picture the offense.
Exact. Yeah. We naturally focus on the attack, the direct strike against the tumor.
But what if the most devastating roadblock in cancer care happens when the weapon works well, a little too well, and the body just can't take it anymore? Welcome to today's deep dive. If you're looking for an aha moment that changes how you view medical science, you are in the right place.
You really are, because today we are looking at something that usually flies completely under the radar.
Right. We are analyzing excerpts from a single source today, a phase 3 clinical trial. And it's titled Romiplostim for the Management of Chemotherapy-Induced Thrombocytopenia.
It's quite a mouthful.
Yeah, it is. But our mission today is to unpack this massive, often invisible hurdle in oncology. Like, what happens when a life-saving cure actually has to be paused? And we're going to explore how this single trial is trying to keep those critical treatments on track.
And it's a dense title, I know, but the stakes behind those words are absolute life and death. I mean, we are talking about patients facing incredibly aggressive cancers where every single day of treatment matters.
Yeah.
The research we're looking at, it represents a fundamental shift in how we might care for our most vulnerable patients. It's moving the focus from, just attacking the cancer to actually fortifying the patient.
Which is such a fascinating puzzle. But before we look at the solution, we really need to look at the mechanics of the problem, right?
Right.
We have to understand the specific roadblock that brings cancer treatment to a grinding halt.
Right.
So the medical term used in our source is chemotherapy-induced thrombocytopenia, or CIT for short.
Right, CIT. And to break that down, thrombocytopenia simply means a dangerously low blood platelet count. Platelets are the tiny sort of disc-shaped cells in your blood that help it clot. So if you get a cut, they rush to the site and bind together to stop the bleeding.
Makes sense.
So chemotherapy-induced thrombocytopenia means the chemotherapy drugs have inadvertently caused the patient's platelet count to just crash.
And the source material highlights exactly what this causes. It leads to a high risk of bleeding, potentially worse overall outcomes for the patient, and critically, something the researchers call reduced relative dose intensity.
Yeah, that phrase, reduced relative dose intensity, that is the absolute core of the problem here.
Because it sounds so clinical, but it's devastating, isn't it?
It is. To understand why it happens, you have to look at what the chemotherapy is actually doing inside the body.
Right, because the trial specifically mentions these patients are on, quote, oxaliplatin-based multi-agent cytotoxic chemotherapy, which, I mean, that just sounds incredibly intense.
Oh, it is. They're using a cocktail of cellular poisons. Cytotoxic chemotherapy is essentially a scorched earth tactic. It targets rapidly dividing cells, which, cancer cells are. But the drugs aren't smart enough to only target the cancer.
Right. They just hit everything that divides fast.
Exactly. And the bone marrow, where your body manufactures blood cells and platelets, is also full of rapidly dividing cells.
Oh, I see.
So the bone marrow gets caught in the crossfire. The factory is making your platelets get temporarily shut down.
Which leads right back to that phrase, reduced relative dose intensity.
Yeah.
Let's look at the actual mechanics of this from the patient's perspective.
Okay.
So imagine you are on a cross-country rescue mission. It is a life-or-death emergency. Your chemotherapy is your high-speed rescue vehicle.
I like this analogy.
Right. So it's powerful, it's fast, and it's doing exactly what it's supposed to do. It's racing toward the target to save the day.
Mm-hmm.
But developing CIT, that bone marrow collateral damage causing the low platelets, that is exactly like blowing out your tires on the highway.
That paints the picture perfectly.
Yeah. Because the blown tires don't mean your engine is broken. Like, the drug still works.
Yeah.
But you are forced to pull over. You have to delay the trip, or maybe you have to swap out for temporary tires and just drive at half speed.
Right.
And what happens while you are pulled over on the side of the road, the enemy, the cancer, is given free time to gain ground.
Exactly.
That is reduced relative dose intensity. You aren't hitting the cancer as hard or as often as you absolutely need to.
And, you really have to consider the psychological and physical toll of that on a stage 4 patient.
I can't even imagine.
Right, because you gear yourself up for this grueling treatment. You know it's going to make you sick, but you know it's your best chance at survival. You show up at the clinic, they draw your blood, and the oncologist comes in and says, I'm sorry, your platelets are too low. It's too dangerous to give you the chemo today.
Wait, because of the bleeding risk.
Yes, they'll say, you could suffer a fatal internal bleed.
So they just send you home.
They just send you home. The doctors are forced to reduce the dose, delay the next cycle, or sometimes stop the chemotherapy entirely.
Oh, wow.
You have the drug that could save their life sitting right there in the IV bag, and you're simply not allowed to turn the dial.
And here is the stark reality pulled straight from our source text. Currently, there are no widely available therapies approved for CIT. None.
It's incredibly frustrating.
They'll blow your tires, and there is no approved roadside assistance coming to help you fix them. You just have to wait and hope your bone marrow recovers on its own before the cancer spreads.
So if you're an oncologist watching your patient's platelets crash and you have no approved tools to fix it, you're forced into a corner.
Right.
And that desperation is exactly what birthed this trial. They needed to test if an experimental drug called Romiplostim could act as a synthetic bridge to stimulate the bone marrow and keep those platelets alive.
Which brings us right into the design of the phase 3 trial detailed in our source. Since there are no approved therapies, how do they even test a fix?
Yeah.
Right?
And it is worth noting the rigor here. This wasn't some small exploratory study. This was an international, double-blind, randomized, placebo-controlled phase 3 trial.
The gold standard.
The absolute gold standard of clinical research. They were rigorously testing whether Romiplostim could actually solve the CIT crisis, and they designed the trial to eliminate as much bias as humanly possible.
Let's look at the patient profile, because this is where the stakes of this trial get very, very real. The trial involved 165 patients. They were all receiving that heavy-duty oxaliplatin-based chemotherapy for gastrointestinal cancers.
Right.
And breaking the numbers down, 75% had colorectal cancer, 13% had gastroesophageal cancer, and 12% had pancreatic cancer.
And these are notoriously relentless, difficult-to-treat cancers.
Yeah.
The digestive system is a complex environment, and tumors here often require intense, uninterrupted regimens of that scorched earth chemotherapy we talked about, just to keep them from spreading.
And the disease severity in this specific group is severe. 72% of the patients in the Romiplostim group and 61% of those in the placebo group had stage 4 disease.
Stage 4.
Yeah, these are patients whose cancer has already spread to other parts of the body. Time is absolutely not a luxury they have.
Every single chemo cycle is critical. Now, to even qualify for this trial, these patients had to have a documented history of persistent CIT.
Oh?
The baseline threshold was a platelet count of 85 times 10 to the 9th per liter or less on trial day 1.
To put that in context, a normal platelet count is usually somewhere between 150 and 450. So being at 85 or below means their blood's ability to clot is dangerously compromised?
Precisely. They were in the danger zone. They were exactly the patients whose chemotherapy was guaranteed to be derailed.
So researchers took these 165 patients and randomized them in a 2-to-1 ratio. For every 2 patients who received the experimental drug, Romiplostim, 1 patient received a placebo.
Right.
And they were tracked over the course of 3 chemotherapy cycles.
But, as I was reading the source, I noticed something about the trial's design that seemed almost counterintuitive to me.
What was that? The primary endpoint. The main metric the researchers used to determine if the drug was a success was the absence of CIT-induced modifications of the chemotherapy dose in the 2nd and 3rd cycles, meaning they were measuring if the chemo had to be reduced, delayed, omitted, or discontinued.
That's right. That was the ultimate finish line they were aiming for.
But wait, if this is a trial for a drug designed to fix low blood platelets, why aren't they just measuring the platelet numbers? Why wouldn't the primary endpoint just be, did the platelet count go up to a normal level? Why measure the absence of dose modifications?
It is a brilliant question, honestly, because this specific choice of endpoint reveals a profound philosophy shift in modern oncology.
Also,
Well, if you just measure the platelet numbers, you're treating a chart. You're treating a piece of paper. But for a patient with stage 4 colorectal or pancreatic cancer, a beautiful normal number on a lab report does not inherently save their life.
because the platelets themselves don't kill the cancer?
Exactly. The only thing that kills the cancer or extends their life is getting their full, uninterrupted dose of chemotherapy.
Right.
The researchers understood that the goal isn't just to boost platelets for the sake of biological bookkeeping. The goal is to keep the rescue vehicle on the road at top speed. The trial isn't just treating a biomarker, it's treating the patient's ability to actually tolerate the fight.
I see. The platelets are just the mechanism. The uninterrupted chemo is the actual victory.
Exactly.
So knowing those incredibly high stakes and that rigorous setup, What actually happened when the experimental group received Romiplostim?
Well, the results were practically unheard of in this kind of supportive care trial.
Looking at the numbers from the source, the primary endpoint result was just massive. 84% of the patients on Romiplostim, that's 92 out of 109 patients, had no CIT-induced modifications to their chemotherapy.
Zero force delays, zero force reductions because of low platelets.
Wow.
84% of them powered straight through their scheduled heavy-hitting treatment.
And compare that to the placebo group. In the placebo group, only 36%, just 20 out of 56 patients, managed to avoid modifications.
And to understand how big of a gap that is, we really have to look at the statistical weight the trial reported.
Okay.
They documented an odds ratio of 10.16 and a risk ratio of 2.77 with a p-value of less than 0.001.
Okay, let's translate that math for the listener because those aren't just dry statistics.
Right, they mean something real.
Yeah, a p-value of less than 0.001 essentially means there is less than 1 in 1,000 chance that these results were a fluke. This was a direct result of the drug.
Exactly.
But I really want to hover on that odds ratio of 10.16 for a second. If you're looking at these odds ratios right now, you might be wondering what a 10.16 multiplier actually looks like in practice.
It's huge.
It is. Imagine you're trying to push a stalled car up a steep, slick hill in the pouring rain.
Okay.
Normally, given the conditions, you only have about a 36% chance of making it to the top before your grip fails, and you have to stop or slide backward.
Which is exactly what the placebo group experienced. The grip fails, the chemo stops.
Right. Now imagine someone hands you a heavy-duty motorized winch. You aren't just a little better off. Your odds of making it to the top of that hill without sliding backward just jumped tenfold.
Wow.
You have a 10x multiplier of continuous forward momentum. That's an odds ratio of 10.16. It isn't just an improvement, it is a complete paradigm shift for the person pushing the car.
It absolutely is. Jumping from a 36% success rate to an 84% success rate in keeping stage 4 cancer patients on their full treatment schedule alters the entire trajectory of their care.
Yeah.
We are talking about giving the vast majority of these patients their absolute best possible fighting chance. We are ensuring the tumor doesn't get that free time to mutate or grow while we wait for their bone marrow to recover.
We basically have a drug that practically guarantees the chemo train stays on the tracks.
Exactly.
But as anyone who has ever looked at medical research knows, critical thinking demands we look for the catch.
Always. There is no free lunch in medicine, especially in oncology.
Right. What is the cost to the patient's body to keep this high-speed rescue vehicle running? Because I was digging into the section on adverse events in the source, and I'm looking at the safety data and I'm seeing a massive contradiction.
Oh, let's hear it.
The source states that adverse events of grade 3 or higher, which in clinical terms means severe side effects, occurred in 37% of the patients who received Romiplostim.
Okay.
But they only occurred in 22% of the patients who received the placebo. 37% versus 22%.
Right.
Are we actually celebrating a drug that severely hurts patients more than doing nothing? Like, why would doctors want to use a drug that causes nearly double the severe adverse events?
See, this is exactly why you have to read beyond the raw percentages. It's so easy to look at those two numbers and assume Romiplostim is highly toxic.
Well, it certainly looks that way.
But you have to look closely at what the source specifically notes right after that statistic. It says those grade 3 or higher adverse events primarily reflected chemotherapy effects.
Chemotherapy effects, not Romiplostim effects.
Yes. Think back to our primary endpoint. What was happening to the patients in the placebo group?
They were failing the primary endpoint, meaning they had to stop their chemo.
Exactly. The severe events were higher in the Romiplostim group because they were actually receiving their full doses of chemotherapy.
Oh, wow, I see it now.
Right. The placebo group had fewer severe chemo side effects simply because their chemo was being delayed, reduced, or omitted entirely.
Because they weren't getting the full toxic impact of the cancer drugs, because their low platelets forced their doctors to hit the brakes.
Precisely. The Romiplostim patients got their full heavy-hitting chemo over all 3 cycles, and therefore they naturally experienced the full heavy-hitting side effects of that chemo.
It's almost like a survival bias in the data. They suffered more severe chemotherapy side effects because their blood was actually kept strong enough by the Romiplostim to take the hits.
Exactly. It is a paradox of toxicity. They had more side effects because they were actually getting the treatment they needed to fight the cancer.
That is wild.
Now, when the researchers isolated the adverse events that were actually considered by the investigator to be related to the Romiplostim itself or the placebo itself, the picture changes entirely.
Yeah, looking at those isolated numbers, the investigator considered related events were only 12% for Romiplostim versus 7% for the placebo.
Right.
And the most frequent side effects were remarkably mild. Nausea was 2% in both groups. Headache was just 2% in the Romiplostim group.
Extremely mild. And crucially, the source explicitly states that none of the related events were serious, none led to death, and none caused the discontinuation of the Romiplostim, the placebo, or the chemotherapy.
So the drug itself is incredibly well tolerated.
It is.
I do see one other note here in the safety data that we need to address, though. Thromboembolic events.
Ah, yes.
These are blood clotting issues. They occurred in 2% of patients who received Romiplostim and in 0 patients who received the placebo.
Which honestly makes perfect pharmacological sense. If you are artificially stimulating the body to produce more platelets, and remember, platelets are the cells whose entire job is to cause clotting,
Right.
there is a slight logical risk that you might cause an unwanted clot. A 2% risk is not zero, and oncologists have to monitor for that closely. But you have to weigh that in the context of oncology.
Right. When you weigh a 2% risk of a blood clot against an 84% chance of keeping a stage 4 cancer patient on their life-saving chemotherapy regimen, I mean, it's a risk you manage every single time. The benefit is just too massive.
Without question. The inclusion of the trial in the source is brief, but it carries so much weight. It simply states, in this phase 3 placebo-controlled trial, Romiplostim was efficacious in treating CIT.
Efficacious. It's such a quiet scientific word for something that is actually a roaring victory for these patients.
It really is.
So to recap the journey we've been on in this deep dive, chemotherapy-induced thrombocytopenia, or CIT, is a devastating physiological roadblock. The collateral damage to the bone marrow forces doctors to stop life-saving cancer treatments right when the patient needs them most.
Exactly.
But in this rigorous phase 3 trial, the drug Romiplostim essentially acted as a bridge over that roadblock. It allowed 84% of severely ill gastrointestinal cancer patients to power through their chemotherapy without forced delays or reductions, safely, and with very mild drug-related side effects.
It is a phenomenal piece of clinical research. And bringing it back to you, the listener, understanding how clinical trials like this one measure success changes how you read medical news forever.
It really does. It teaches you to look past the surface level numbers.
Exactly. Don't just ask, did the blood test get better? Ask the practical question, did the patient get to keep fighting? Focusing on practical outcomes, like maintaining dose intensity rather than just inflating lab numbers, is the true mark of patient-centered medicine.
It changes the entire paradigm. And it leaves me with this final provocative thought, something for you to mull over long after this deep dive ends.
Okay, let's hear it.
This trial highlights a reality of modern medicine that we rarely talk about. Sometimes the biggest leaps in disease survival don't come from discovering a brand new, magical, cancer-killing drug. Sometimes the breakthrough is simply finding a way to armor the human body against the treatments we already have.
That is a profound shift in perspective. We have these incredible, powerful tools, but the human body's tolerance is often the actual limiting factor.
Exactly, which raises a huge question. How many other powerful cure potential medical treatments are sitting on a shelf somewhere right now, or being used at only half capacity, just waiting for the right supportive therapy to make them viable?
It's a great question.
How many other high-speed rescue vehicles are out there perfectly capable of saving the day, just waiting for a better set of tires so they can finally finish the mission?